Hello everyone, this is Chadi Alraies from SCAI-TV in Atlanta. I'm really privileged today to be with Dr. Sachin Goel. He's the structural heart director at Methodist DeBakey Heart and Vascular, and also he is one of the members of the SCAI Structural Heart Committee. Sachin, always nice to see you.
Thank you, Chadi.
Yeah.
It's always great to see you as well.
One of the challenging, but also kind of we have more information about is the role of TAVR in bicuspid valve evaluation and deployment. Can you give a phenomenal talk about it? Can you please enlighten us about it?
Of course. So bicuspid aortic stenosis is pretty common. We know from the surgical literature that 1 in 5 patients over the age of 80 have actually a bicuspid, and obviously the younger the patients, there is a higher incidence and prevalence of bicuspid aortic valve. So as TAVR expands into the younger and lower surgical risk, we are seeing more and more patients with bicuspid aortic stenosis. As you know, bicuspid aortic valve is the commonest congenital abnormality, and it is present in 0.5 to 2% of the population. It is distinct from the tricuspid aortic or degenerative calcific aortic stenosis in that the valve progression is more rapid. Patients also have an associated aortopathy, and not all bicuspids are the same. There are several nomenclatures for bicuspid. The most common is the Sievers classification, which was proposed back about 15 years ago based on the presence or absence of raphe and the numbers of raphe. So there's type 0, type 1 and type 2, type 1 being the most common with left-right fusion. So that is really important in evaluating these patients. And then more recently, Raj Makar's group evaluated all the bicuspid TAVRs from a multi-center registry, and they proposed a new classification based on the amount of calcium in the raphe and based upon the calcium in the leaflets. And what they found interestingly was patients who had high degree of calcium in a calcified raphe and leaflets, they had the worst prognosis with TAVR compared to patients with not so much or no calcium in the raphe. So we look at all these things on the CT, which becomes very important in evaluating their anatomy and risk for TAVR.
Yeah. So this is the new classification you are proposing, or proposed is depends also on the calcification and fusion or something else?
So yeah, so they have 3 categories. One is just a bicuspid valve without a raphe. The second category is bicuspid with a calcified raphe, and the third is bicuspid with calcified raphe and excessive leaflet calcification. So the ones with excessive calcification, particularly in the raphe, and the amount of calcium in the leaflets, that is the worst sort of prognostically. So if, when we see these patients, if they are low surgical risk and if they are relatively young, then I would tend to favor surgery. Whereas if they're high surgical risk, then we evaluate very carefully the anatomy and discuss the pros and cons, and consider TAVR.
Yeah, would that classification or any other morphology of the valve dictate balloon expandable versus self-expanding valve?
That's a great question. So this has been looked at. Again, I would like to remind everyone that there is no randomized trial for bicuspid versus tricuspid TAVR. All the data are derived from retrospective studies, multi-center studies, TVT ACC registry, and also both the Evolute low risk and the partnered low risk sub-studies. So all this is retrospective. And there are good data. When you look at the retrospective studies, all the cumulative evidence from the TVT suggests that doing TAVR and bicuspid aortic stenosis, again, these are carefully selected patients, is found to be safe. Similar outcomes, at least in the short term and the mid-term, meaning the immediate procedural success, the 30-day outcomes, and then in some of these studies, 1-year outcomes, is more or less same when compared to tricuspid aortic stenosis. There are some subtle differences between balloon expandable and self-expandable, and we and many others have used both valves for treatment of bicuspid aortic stenosis. We tend to favor the self-expandable, especially if there is excessive excessive calcific raphe, because there is concern about risk of annular rupture with the balloon expandable. Although looking at the data, there doesn't appear to be any significant difference.